Alrighty, good afternoon and welcome back everyone. I hope you enjoyed your lunch break. We will now move into our next panel discussion, Navigating Black Healthcare Disparities. Throughout this discussion, panelists will address the long-standing structural and systemic inequities deep-rooted in racism and how those inequalities have disproportionately impacted the Black community. Our speakers will draw on their own experiences and varied professional backgrounds as they tackle the prevailing concern on healthcare inequity and provide recommendations on how we navigate those disparities and improve the overall health of our nation. Joining us today, we have Dr. Tamika Alexander. Dr. Alexander is a board-certified OBGYN who is passionate about patient access to equitable healthcare. She completed her undergraduate studies at Duke, her medical degree at the University of Illinois College of Medicine, Rockford campus, and then completed her residency at the University of Illinois at Chicago. Upon her graduation, Dr. Alexander joined the faculty at UIC, where she began her academic teaching career. She is currently the residency program director for the OBGYN program and is a sought-after expert on topics such as reducing maternal morbidity. Next, we have Dr. Ebony Bower. Dr. Boulware is the Nanaline H. Duke Distinguished Professor of Medicine, Director of the Duke Clinical and Translational Science Institute, Vice Dean for Translational Science, and Associate Vice Chancellor for Translational Research in the School of Medicine at Duke University. She also serves as the Chief of the Division of General Internal Medicine in the Department of Medicine. She received an AB from Vassar College, an MD from Duke University, and an MPH from Johns Hopkins Bloomberg School of Public Health. We are also joined today by Dr. Tama Bryant. Dr. Bryant is a clinical psychologist, and she is also a professor of psychology at Pepperdine University. Dr. Tama Bryant earned her doctorate from Duke University and completed her postdoctoral training at Harvard Medical School. Dr. Tama regularly raises awareness about mental health, which is very important in the Black community, on her Homecoming podcast and on her social media platforms. Also joining us today on her birthday, we have Dr. Elizabeth Claiborne, Duke alum and also one of my classmates. Dr. Claiborne was always an innovator, creating her own major in medical ethics and religion while attending Duke. She went on to attend Case Western Reserve University, and there she completed a dual MD, MA bioethics degree. She did her residency at the George Washington University Hospital. Currently, Dr. Claiborne is a faculty member at the University of Maryland School of Medicine, Department of Emergency Medicine. Her face may seem familiar to you as she has been featured on several national networks such as CNN and MSNBC in the past 2 years to discuss COVID-19. And remember I said she is an innovator. Dr. Claiborne also developed a novel nosebleed device, NasoClip, and that will launch the Class 1 version of the device this summer. Like Dr. Claiborne, we have another entrepreneur on the panel, and that is Mr. Kareem Cook. Kareem is a founder and managing director at Towerview Capital Management, a private equity firm specializing in leverage buyouts of companies focused on preventative medicine, healthier products, and healthier lifestyles. His journey in the health and wellness space, he acquired NatureAid in 2012 and is currently the chief marketing officer there. But prior to that, he actually co-founded Healthy Body Products, a healthy beverage and snack distribution company based in LA. He earned his BA from Duke University in 1994 and his MBA from Duke University's Fuqua School of Business in 2000. He also currently serves, wearing 2 hats today, on the Duke Alumni Association Board of Directors. Also joining us today is Dr. Vincent Roddy, another Duke graduate and another classmate of mine. Dr. Roddy completed his medical training at Virginia Commonwealth University School of Medicine and his residency at the Icahn School of Medicine at Mount Sinai. Next weekend, Dr. Roddy will graduate from Duke University's Fuqua School of Business Executive MBA program. He currently works full-time at North Shore Medical Center as the Facility Medical Director. And like Dr. Claiborne, Dr. Roddy also speaks on issues of healthcare equity and has been featured in Essence discussing COVID. Last but certainly not least, we have our moderator, and that is Chancellor of Health Affairs at Duke University, Dr. Gene Washington. Dr. Washington's career spans more than 25 years, and he has held numerous academic leadership and senior executive positions in 3 prominent academic health systems. Dr. Washington has published extensively in his major areas of research, which include prenatal genetic testing and racial ethnic disparities in health outcomes. Dr. Washington is a 1976 graduate of the USCF School of Medicine. He completed his undergraduate studies at Howard University, his graduate studies at both UC Berkeley and Harvard Schools of Public Health, and his residency training at Stanford University. In short, you have a very qualified panel here today. And with that said, I'm gonna go ahead and turn it over to Dr. Washington.
Thank you, Tadena Simpson. Good afternoon, everyone. On behalf of all of us at Duke, I extend a warm welcome to you. And for those of you who are returning, welcome back. We're a campus that's dynamic and is constantly changing and evolving, and I've heard a couple of my panelists already comment that this is a very different page auditorium from when they were here. I have the great pleasure, actually, I consider it an honor to be the moderator today, given that we have such a distinguished group of panelists here, and as you've heard, very diverse backgrounds, and so we're going to tap into their deep insight as we take on this question of navigating health disparities. But I want to broaden it a little bit, because some of you have heard of us refer to it as healthcare disparities. Some of you have heard of it referred to as health disparities. In other settings, it's healthcare inequity. In other settings, it's health inequity. What do we talk? How do we line these up? So just to kind of set the foundation, I'm going to ask one of our panelists, one who I happen to work with on occasion, Dr. Boulware, to line these terms up for us just as a foundation for our discussion this afternoon.
Absolutely, and hi everyone and welcome. Very great to see you. Hope you enjoy your visit and your time here back at Duke. When we talk about disparities and equity, we're talking about 2 related but somewhat different concepts. So a disparity is a difference. So in the case of health, we might say there's a difference in health in one group versus another group. But an inequity is also a difference, but for different reasons. So I'll give an example that might illustrate this. We might see a difference in breast cancer between people who have been assigned a male sex versus female sex. And that difference is likely because of the biological difference of one group having breasts and the other group being less likely to have breasts. So the difference in the disparity in the breast cancer rate is because of a biological difference. In an inequity, it's a situation where everybody should have the same capability of having health, but one group is not is reaching that capability versus another. So let's give an example of heart disease. If we find that individuals in one group, say Black individuals, have higher rates of heart disease than individuals who are not Black, that may be due to an inequity, and that's because certain opportunities or certain barriers may get in the way of people achieving the common level of health. So there's 2 things there, a difference between disparity and a difference between an inequity. Inequity usually implies that there's a difference in the types of resources or opportunities that get in the way of people achieving similar health. And then when we think about health versus health care, I just talked about 2 health examples. So this is your physical capability to have a well-being. Healthcare is actually the delivery of services that we would provide in public health or in clinical medicine. When you go to the emergency room or you go to your doctor's office or you're in the hospital, it's the quality of the types of care that you're being delivered. So just when we talk about health, we're talking about the full picture, how you feel as an individual. We talk about healthcare, we're talking about what kinds of services do you receive. And in the case of healthcare, I think we're often thinking about equity in healthcare.
We could certainly spend the entire time talking about the use of this language in the lexicon, but let's let that serve as a foundation, and then let's move on to the question of how did we get here? What's underneath this? What's caused it? Without enumerating for you, whether you're talking about any of the leading causes of death, we tend to see both health and healthcare disparities and health and healthcare inequities, whether that's cancer, whether it's heart disease, whether it's stroke, whether it's obviously COVID. So I'm looking for volunteers here. What's underneath this? What's causing these disparities? Please.
I can hop in.
Dr. Roddy.
Well, thank you. I can hop in and comment on that. The other doctor had mentioned that, healthcare was essentially the distribution or the giving out of healthcare services. And in my career as a physician, I've definitely seen inequities in the different types of hospitals that I've worked at. When I've worked at hospitals that are in more affluent locations, serving a quote-unquote, more affluent clientele, it's easier for the patients to come into the emergency department and to receive the care and the treatment that they need. Why is that? Usually the facility is physically nicer. It's better staffed. The radiologic services that we use, MRI machines, CAT scanners, whatnot, are more reliable. They don't break down. Currently, I work at a hospital that serves an indigent community. It's mostly an immigrant community, a non-speaking community, like a lowered income community. And although we have great physicians and nurses that work there, the infrastructure of the hospital has been underinvested in. And Dean, to your point, how did we get here? Well, a lot of the hospitals that are in indigent communities really just don't have the funding that they would need to provide the type of healthcare services that patients require and need. Look at what's happened during the pandemic. When you hear doctors say and healthcare professionals say that the pandemic has unearthed healthcare inequities that exist in our system, what are they talking about? Well, they're talking about when people needed to get COVID tests. If you were in a more affluent neighborhood, you could get one on demand. You could probably get numerous tests if you wanted to. If you needed access to PPE, you could get that as well. N95 masks, KN95 masks, the actual pieces of equipment that you needed to prevent infection. Staffing resources, there's huge, nursing staffing shortages in hospitals all across America. Now, I can tell you that this affected our site tremendously. And although the physicians were there and the staff that we had were there and we did our best to help patients, if you're not fully staffed, patients wait longer for services. And so they might become discouraged and may not want to come to the hospital or may choose to go somewhere else, and they may ultimately be delayed in getting what they need. So as far as how we got here, we have a lot of money in the United States, but they say, show me your budget, you see your priorities, right? So if we're not actually investing in communities of color, if we're not actually investing in hospitals in communities of need, because a hospital is essentially a public good, it will ultimately be passed on to the patients and to the community. And that's something that needs to be fixed. We need to discuss that openly and loudly so that we can petition the federal government or private companies to make the needed investments in our communities so that we can do the work for the people that is required and needed.
Thank you, Dr. Roddy. Mr. Cook.
So I own a company called Nature 8, and this is the first time I've been on a panel of doctors, and I'm not a doctor. But the reason I'm here is because we're all addressing the same issues. We just address it from I address it from the preventative side. I sell weight loss products, gut health products, meal replacements, predominantly plant-based. And what we're trying to do is have less people go see these people, right? And the reason that this is happening is because, I'll just give you a concrete example. Our vision and mission is to reverse pre-diabetes and diet-related illnesses in communities of color, right? There are 130 million people who are pre-diabetic. The healthcare industry, the supplements industry is a $20 billion industry, and they're both growing. How can that exist? It's because they're selling to the wrong people. They're selling to the people who don't need it. And a prime example of that is Natural Expo West is the biggest natural products conference in the world. 100,000 people attended. 100,000 people attend this conference, right, every year. We are one of 20 companies that are there, right? When we go to the Essence Festival, where there's women of color, we're the only company there talking to the community of people who need it the most. And so that's what's happening. We're being ignored in terms of products being given to the people who need it the most. You know, one of the things we like to say is we sell whole food quality products to the Walmart consumer. Why should my mom, who grew up in the Bronx, New York, have to get on a bus and a train to get to a Whole Foods when she should be able to go right downstairs and get the same quality of products? And so that's what we're trying to fix, and that's part of the reason.
Okay, Dr. Alexander, and then Dr. Bryant, please.
From my perspective, I'm a medical educator, and so I work with medical students and undergrads who want to go into medical school. And I think part of the problem that in this bias that we see is how we deliver medical education. So when we went to medical school, we had these dreams of going out and saving the world. Like, I thought that I could take care of patients without getting paid. What they would do is just give me a pie and I would take care of you in return. And then we find out that, you know, you can't deliver you can't deliver healthcare like that. There's like things that are keeping you to like insurance and liability and such. So you can't provide care like that. But fundamentally, what we teach in medical school are biases. We teach our students that Asian people are this way, Black people are this way, white people are this way. And so when they get this education, they go into their clerkships and they start treating patients based on what they believe. So they believe that if it's a Black patients are the only ones that could have sickle cell disease. So they go in thinking, well, this patient looks Asian to me, so there's no way she could have sickle cell disease. And they miss a diagnosis because of that. Or they say that, oh, this person lives in a low income area, and they have to have Medicaid, and so they go to the emergency room because they don't really care about their health care. So it starts at the medical school for me, in talking to these people who are actually gonna be the ones delivering the health care in the future to try to eliminate some of these biases so that there isn't a discrepancy in how health care is delivered.
So you're saying on top of the inherent biases that are there just in our societies that you see every day, throughout the day, we're actually reinforcing it in some of our training.
Yes.
Good point. Dr. Bryant, please.
Yes.
And while you have the mic, you have to comment about mental health and the disparities.
That is exactly what I'm going to talk about. So I am the president-elect of the American Psychological Association, and I am so glad for us to include mental health in this health conversation. And I want to say explicitly what is underneath our disparities: racism. I want to say that very, very clearly. That is the problem, fundamentally, the realities of white supremacy. And so sometimes we are uncomfortable calling a thing, but if we listen to the panels from this morning, a lot of what people were talking about was what we call racial battle fatigue. It is exhausting to deal with the emotional labor of facing people who underestimate you, who devalue, who seek to erase you. It is exhausting. And so a lot of our despair, frustration, addiction can be tied back to that. And that shows up in terms of intersectionality as well, of what does it look like for gendered racism? What does it look like for LGBTQ people of color? That there is a multiplicative effect on our emotional well-being. And so to address that, we have to really be actively anti-racist in shifting systems. So a lot of times people are comfortable talking about bias because bias is on the individual level, and it's like, oh, everybody has biases, and so we just have to accept that. This is structural, and it is systemic, and it is institutionalized, which is why I'm so glad you talked about the training and the education, because it is baked into the very system. And so eradicating racism is a public health requirement.
I think Dr. Bryant's comments are right on time, and I just recently published a paper that came out in the Hastings Center's report that was entitled racism, not race, a physician perspective on anti-Black racism in the United States. And in this paper, it talks about that a lot of times when you discuss health inequities or health disparities, we bring up terms of social determinants of health. Like these individuals and groups are disadvantaged because there's something in their environment that's contributing to them not performing as well as other groups, and that's a societal structural issue. But what it doesn't address is that those social inequities of health have a root cause, the actual disease, which is racism in this country. And as she said, I feel like our institutions are uncomfortable with addressing the real disease. So we continue to treat the symptoms, which is very similar to what we do in healthcare, which is take care of sicknesses and not prevent disease to begin with. And so in order to prevent inequities of health, we have to go to the root cause, which is racism, and that is much more difficult work. For me, it begins with having better representation in the healthcare systems altogether, especially at the top with leadership. You may not know this, but the number of Black physicians that we have in the United States as of 2018 was only 5.6%, despite the fact that we represent 13% of the population. So we have a lot of work to do because those biases will not be undone. Real change will not happen if we do not have representation that allows us a lens to see where our weaknesses and problems exist.
That's great.
I would just like to make a quick point because they're making excellent points. And I just want to give it like an example of what that would look like. What does structural racism in healthcare actually look like? As Liz knows this, we're both emergency physicians and I run an ER in Miami. If a patient comes in for a drug overdose and it's, crack related or if it's marijuana related, not that you necessarily could overdose on that, but if it's marijuana or crack related, usually those patients get arrested. They will leave the ER after being treated in handcuffs. And unfortunately, most of the time, these are Black or brown persons being arrested. Now, you know what a drug conviction or a drug arrest would actually do for your prospects of having a successful life here in the United States. Obviously, it's gonna hurt. It's gonna hurt tremendously. Now, on the flip side, I live in South Florida, and the opiate addiction or the opiate I guess you can call it a pandemic or whatever you would call it. That's huge in South Florida. It was huge when I moved there 10 years ago. It's still huge now. So if a patient were to be brought in by EMS with the police in tow for a heroin overdose, they could even have drugs on them. They could have drugs on them. They could have drug paraphernalia on them. You give them the antidote, the Narcan for the opiate overdose. They wake up angry. They run out of the ER. There's no charges. There's no blemish on your record. And most of the time, these are young white kids. And so when I used to work in Fort Lauderdale, I worked at the Level 1 Trauma Center there. As the only Black physician in our group during the 5.5 years I was working there, I'd publicly question the police. Why is this? Why this inequity? Drug abuse is a social disorder. It's a mental disorder, and it shouldn't be criminalized. But I'm sitting here watching, Black and brown people be arrested for these, drug offenses, and I'm watching our white counterparts essentially just be given a slap on the wrist, don't do it again, let go. Of course, they come in, next week. Probably for the same thing. So, it's one thing to talk about structural racism existing in healthcare. It's another thing to actually give you a specific example that I've seen countless times happen throughout my 13 years as a physician, affect our patients. And you see how, one group of persons are not affected by it, another group of persons are labeled criminals, labeled thugs. There's just a total lack of empathy. And to Liz's point, it will never be fixed unless there's more of us in healthcare asking these questions, making these points, essentially being the leaders that our community needs.
But when you try to establish an anti-racist curriculum, for example, in a medical school, unfortunately, that falls upon us. And so when you're trying to actively be anti-racist and you're trying to enforce that, at some point, there's only so much you can do. You do have occasional allies, but generally speaking, when in education, we established an anti-racism curriculum or tried to be anti-racist at our medical school at UIC, and it was it was in 2020, and literally, they just kept coming to all the Black faculty. Well, what should we do about this? And what should we do about that? While we're still experiencing racism as faculty members working there, While we're still experiencing racism when we see our patients, when we take care of them, and we're usually put in the clinics or the places where there's less resources, then you want me to also teach you how to be anti-racist. It's exhausting. Like, it's completely exhausting. And I think that's something that we need to talk about, is that if you want to become anti-racist, then you do the research how to do that. That's not my responsibility necessarily to teach you how to be anti-racist. So while I totally agree with you, as an educator, what you said about racism fatigue, it is so true. Every day they want, can you give us a talk on such and such? I'm not an expert on that. All I know is what I experience every day. And it's just too much.
Yeah, we're going to shift gears in a minute. I want to allow Dr. Boulware to comment here. And then we're going to focus on interventions. What can we do? I mean, we have a panel of leaders here, distinguished records of achievement, but that achievement has certainly been met in the past by obstacles, and you've broken through those, and you have some sense now of what would be the most important things for us to do at an individual level, at a community level, more broadly, policy, from entrepreneurship all the way up to care to what we do in our community. But before we shift to that, though, Dr. Boulware, last comment on.
Well, maybe my comment is preamble to that. This segue is that the health inequity is the symptom, and the root cause, again, is structural racism. And structural racism is important to understand, to recognize, as we all do, that it intertwines itself throughout every single aspect of our existence. So it's in every sector that we encounter. It's in business, it's in healthcare, it's in education, it's in every aspect of what we do. It's embedded into our culture and our thinking. And so in order to really do something about it, we can't think that we're only going to target, for example, healthcare education or healthcare delivery and eliminate the problem of health inequities. We really need to address opportunities for employment, healthy housing opportunities, the quality of our neighborhoods, the insurance and the policies that we're subject to, the criminal justice system. All of those things need to be addressed at a root and fundamental cause if we're going to eliminate health inequities.
So that underscores, in my mind, why this moment we're in right now, where social justice and diversity and equity and inclusion is at the forefront. It's being talked about in a way, and even some actions are being taken in a manner that hasn't happened in the past. So let's think about how we leverage this moment and what are the kinds of steps that we should be taking. I will put our audience on notice that we're going to ask you what's on your mind relative to questions to this. So those of you who are nodding, wake up, because I will just point and call you out in a few minutes and put a mic in your hands. But at any rate, and that's in the next 15 minutes or so. But before we get to that, I'm going to ask Dr. Bryant, you have a book just published. I mean, it's hot off the press. Tell us about the book, but
yes.
What you... Yeah.
And I'm so glad my co-author is here, Dr. Edith Arrington, the Anti-Racism Handbook, and we'll have it this afternoon, and also a holistic mental health book that I published this month called Homecoming. First, I want to commend Dr. Alexander about setting the boundary, because it is true that people will try to exploit us for labor, and labor that we are not being compensated for. And so corporations, universities, they have money and they pay for the things they value. But when it comes to diversity and anti-racism, they want to tag it onto your job because of the race you were born, that suddenly you are supposed to be an expert. And so it is important to say no, and that no doesn't mean, so now we're not going to have anti-racism training. It is, yes, we do need to have that, and that is a job in and of itself. And so you all need to compensate people. No more free labor, no more free labor, no more free labor. So structurally, in terms of mental health, One, APA, the American Psychological Association, this past year, our governance, our council, which is about 100 people, voted unanimously for APA to apologize for the role of psychology in promoting and maintaining racism. That was huge. That was huge. And, you know, you often have that backlash of people saying like, well, it wasn't me, right? All these things were a long time ago and I didn't do it. Well, it continues to today. There have been some critics of the apology, and I affirm their response of the apology is insufficient. And what I say to that is it was necessary. People need to name that they have done wrong, and then it is also insufficient. And so the next response after that is, you know, what many have termed decolonizing psychology or indigenizing psychology, what I say psychology for the people. So having more access to entering into the field. And so that includes scholarships, that includes awareness raising so we can remove the stigma around mental health. It also includes culturally informed interventions instead of these cookie cutter approaches. And so in education, in research, in practice, and consultation, not just having cultural awareness. So many have critiqued this term cultural competence because it implies an endpoint. So people went to one workshop, they read one book, and they're like, I'm culturally competent. And traditionally, cultural competence is awareness, knowledge, and skills. And we would say, from a liberation standpoint, that it's not just awareness of culture that we need, but actively being anti-oppression. And in order for people to do that, they have to be taught. So we have many faculty members, many supervisors who, if I said to them, do you oppose racism? They would say yes. If I say, how does that show up in your practice? They would stumble. And I think it is not because they're being insincere, but they are practicing the way they were taught to practice. And so it really requires a re-education.
You know, please go on.
I just wanted to add that I think another essential pillar to this conversation is targeted towards decentering whiteness, right? Whiteness is the norm in this country. You know, I was educated from white knowledge, white bodies, white culture. So even though I'm a Black female physician, my training inherently biased me against providing appropriate care for different kinds of people. And in modern society, everyone likes to say, we're past race, we're better than race, you know, everyone's equal. And what that does is it just disservices the people who do the marking and those who are marked, right? It's easier for white people to say, we're not gonna talk about race because we wanna treat everyone equally. Right. Everyone's not equal. Right. So when you say that, it actually exacerbates the problem. So you have to identify whiteness as being centered and decenter it. And how you do that is hold institutions accountable for having changes which basically have been encouraging the systemic racism, and some actual metrics that they have to be held up against that are showing that, look, we're not always comparing this as the norm, that we expect everyone to fall in line with what historically has been taught.
Great. Well, we'd like to hear from each panel member on this, but in particular, there's a sector here that you represent, Mr. Cook, which is the private sector, in particular, private equity. You know, you guys have all the money. So give us some direction here. What should be the role of...
Well, look, first of all, we don't have all the money. White people have given me all the money I have. But I will say that it's really incumbent upon us to be bold, right? I think what we all have in common is that we're passionate about these issues. And if I didn't know that I was gonna fail organic chemistry, I probably would have been a doctor. But all I could do is use my business training to address the problem from the perspective that I could. And so when I moved to California, and I thought that was gonna be Baywatch out there, but instead I saw all these overweight kids, and I saw the problem right in my face, then it was time to act. And what we did was, we said, well, what if we took all the junk out of the vending machines in the schools and started a company? Claude Tellis is my business partner, he's also Duke 95. And I'll just say that within 2 years, not only did we get the law changed, banning junk food in all the schools in LA and eventually state of California between the hours 8 and 4.
That's awesome. That's awesome.
But we also went to war with Coke and Pepsi, where I ended up cursing out a VP of Coke who got on a plane and came to California just to get cursed out and get back on a plane. But we also ended up with a contract for every single public high school and middle school in Los Angeles. So it's about being bold. It's about being in those rooms and doing what we were there. And I'll give you another example. So I won't tell you the company, but you'll probably figure it out. But I ended up getting a meeting with a CEO of a large retailer. And in that meeting, I said to this person, you know, they were talking about how they care about diversity at the C-suite and diversity of vendors. And I said, you know, to myself, I'm in this room, I have to speak, I represent a lot of people, and they need to hear this. And I said to this person, well, look, you sound like a great person, and I think you have a great heart, but what you practice is systemic racism. And I'll tell you why. In order to qualify to be in the Costco, the average product does 50 million in sales in Costco. Costco doesn't, oops, I said the name. Don't record it. Don't record it, don't record it. Don't get me kicked out of Costco.
You need to grab the recording when you leave the stage.
Yeah, let me get that tape.
Yeah.
So in order to be 50, how many black-owned companies do you know that are doing 250 million in sales such that Costco could be 20% of their revenues and qualify to be in Costco? Zero. You will never have a black-owned company in Costco because, and it's not the Proud Boys, this is what I said, it's not the Proud Boys, not the Trump, it's not the KKK, it's the CFO and the CEO sitting in this room right here. You all have the power to change that. And so that's what we call systemic racism. And he said, well, what if we give you 5 stores? And ended up giving us 40 stores. And I also said in that meeting, you know, Costco's putting $300 million into a bank that's just, getting interest. You know, why don't you put some of that in some black banks? He said, do you know any black banks? I said, actually, I do. And I gave the name, and to their credit, a month later, they put $25 million into some black banks. And the other thing they did was, he said, well, look, we're rolling. What else can we be doing? I said, well, I'm glad you asked that too. He said, my personal ministry is I like to invest in inner city education. I said, well, look, I'm from the Bronx, and I was in a program that led to me getting to a private school and going to Duke. You can invest in that program and a few others. And he said, well, half the proceeds from the sales of your product will do that. And so my point is, it's up to us as business leaders that when we're in that room and we don't have a duty like sales reps in the 60s, your job was to be inside the house when the door closed. Our job is to be inside the house, but we have to stick back our foot and leave the door open for others to come behind us. And we have a duty to perform on a level because they've never seen a unicorn before. So now every unicorn they're gonna see after me, they're gonna think about me. And so we have to perform at the highest levels. We have to think about us, and if we don't do anything, and we're talking about health, if we don't do anything to change our quality of health, our education, then no one's gonna do it.
That's true. Well said. Now, we're gonna encourage you to come up to the mic. We're gonna continue our discussion here, responding to questions that we feel you would want to hear about, but we wanna hear directly from you based on questions that you brought into the room or that you might have now as a result of the discussion. So we're going to turn to you in just a minute. But one or two of you touched up on the intersection of gender and race, and particularly how that presents a unique challenge in health and healthcare for Black women. So we have the benefit of having 4 very distinguished and accomplished Black women. So, comments?
So in terms of Black women's mental health, one of the big pieces to address is post-traumatic stress disorder. So Black girls and women are at increased risk for sexual assault, for severe intimate partner violence, And in terms of domestic sex trafficking, the ethnic group that is facing the highest risk is Black girls in America. So the fact that we don't have public outcry or even awareness that we are the most vulnerable of that group is really problematic. So the realities of violence, trauma, and abuse within our communities are pervasive, and the consequences are long-lasting. On top of the trauma, we have the pressure of being the superwoman and that strength that often gets highlighted to the point of erasure. And so we are supposed to be able to take care of everything and be a rehabilitation center for everyone and deny our own needs. And so what we find in our psychology research is Black women who rate very high in the quote-unquote superwoman syndrome report really low skills in condom negotiation, report a lot of distress in their interpersonal relationships. And so we can get applauded and celebrated for erasing ourselves. And it is important for us to know that our wellness matters, that our wholeness matters, that we are not just here to carry on our shoulders the weight of our communities and families and institutions, that many times we are told that we have to be the strong one, and then at the same time we are demonized for our strength and are called emasculating. And so it is important for us to have a soft place to land with each other and within ourselves.
Thank you. Any other comments here? Well, I want to go back to a comment that you made, Dr. Claiborne, regarding kind of broadening the lens and thinking about these other determinants. Yes, racism is foundational. It's there, it's systemic, it's structural. We know we need to work on that. But there are these other social and economic determinants of health, including environmental as well. What are the partnerships and alliances that we need to be thinking about in order to address these underlying root causes of health beyond just healthcare?
I think what's frustrating for me as an ER doctor is I just see this cycle of patients coming into me with out of control, multiple comorbidities, right? And what is apparent to me as a physician who takes care of a predominantly Black population in Maryland is that being born Black in this country means you were disadvantaged in utero when you were being born, when you were a child with asthma that couldn't get appropriate care, when you're an older person with hypertension and can't find a primary care doctor, or even at the end of your life when you have a cancer diagnosis and your pain is not controlled and there's no access to palliative care. So literally through the entire trajectory of your life in this country, you're disadvantaged for different reasons. And there are access points where we need to do a better job of addressing this. And the reason it's frustrating when they keep coming into the ER for it is I feel like we try to do what we can in that acute setting, but then we just return them to an environment that produced that inequity. So it's like a cycle that we will never win because we're returning them to the same environment that's creating their health issues. So I do think that there has to be a better awareness of health as an overall wellness goal, right? This is not a sick care system. Sick care systems is what eats up 20% of our GDP and why we're so inefficient with healthcare in the United States. Part of that stems from the fact that we use medicine as a business, which it was never meant to be, right? That's why we have the issues that we have. Medicine was always meant to be a service, but we have it very business driven, and it impacts every access of the care. The people who work, in healthcare, that's why we have 1 in 5 healthcare workers currently leaving the profession altogether after COVID, because we're done. You cannot pay me enough money to deal with this nonsense any longer. And then I'm getting burnt out, I depersonalize my patients, and that means that their care is even worse than it was before. So treating medicine like a business, I think, is one of the biggest issues we have. And in the United States, we've just been sustaining the unsustainable for so long. We kept reaching things, saying we're going to reach this cliff, we're going to, max out, we're not going to be able to do this, but we just extend. We gotta find that finish line somewhere where we're just like, look, there has to be a huge shift in the way that we're delivering health care in this country so that it's not sick care, but it's something that's supporting the health of an individual throughout their life.
Right. Ebony, you have overseen a center whose mission is to drive these kind of partnerships and alliances to address these socioeconomic determinants of health. What do those partnerships look like, and how do you go about forging them?
They look like, so we have the Center for Community and Population Health Improvement here at Duke, and our focus is to improve health and health equity through alliances between the healthcare system, our academic enterprise, and community partners. And we do this by partnering up with groups such as our County Department of Public Health, to develop strategies to educate folks about health and programs to reach out to people in their communities around health. We partner with community organizations, local organizations, for example, a coalition of Black organizations and Latinx organizations to help with education. In the COVID-19 era, we were helping with distributing vaccines into folks' communities, getting out into the communities, partnering with the business sector as well, including health insurance organizations, to come up with creative strategies to work on prevention as opposed to sick care. So it's this multi-sector approach that is needed if we're going to really address the health inequities. It's not going to necessarily come from inside the healthcare system. It's going to come from the types of things that you were talking about, Mr. Cook, these outside of the healthcare efforts to really boost the capacity of our whole society to improve health.
Okay. Any other comments on this question? Because, please go on, Dr. Roddy.
I would just say one thing. I mean, Dr. Claiborne here mentioned that healthcare spending was almost 20% of US GDP. As of probably last year, I think it's 18%. I mean, what I tell my patients, there are a lot of social, determinants of health, obviously, that affect our communities. At some point, people do need to try to live healthier lives. It's really just that simple. Now, where would that actually start? Probably when you're young. I mean, what's the answer? I mean, you hear all these problems that we're discussing on the stage. I mean, there is no one answer. It has to be multifactorial. There's opportunities for everyone in this room to affect change as it relates to Black people and persons of color being more healthy in this country. It could be a business solution. It could be a healthcare solution. It could be an educational solution. It could be a mental health solution, right? I mean, all of these things are if you corrected all of these different things, it actually might lead up to a great change. But I tell my patients this, and I'm just gonna say it bluntly. I mean, if you drink or do drugs, you really should not. That's obviously not gonna help you be healthy, right? Drinking and access, lack of aerobic exercise. You should probably prioritize a somewhat plant-based diet, as it's been shown that animal-based proteins, are essentially carcinogens and will increase your risk for developing cancers by like 40 times that relative to a plant-based diet. So, I mean, at some point, this needs to become popular in this country. I don't know how we do that. I think it needs to be discussed explicitly. It needs to be driven into the minds of the American, citizen. And it needs to not be politicized, which, good luck with that, not politicizing something in this country. I mean, everything, somehow that's a political statement, I'm sure. But, I tell my patients this, and I'm just gonna say one thing. I did disagree with one point in terms of like healthcare being a business. I don't think that that's bad, and I'm gonna explain why. I mean, no profit, no purpose. I mean, you have to actually pay the staff something to get them to come to work. As Liz said, it's difficult. I mean, when you're a physician, and many of us didn't know this before you actually went to medical school, you're a servant. You're essentially a quote unquote high paid servant. You're serving people every day, every moment that you're at work. There are no lunch breaks, there are no bathroom breaks. You're constantly working. And so if you want to keep people engaged into that, you have to actually compensate them at a fair rate that's commensurate with their years of experience, years of studying, as we're living in a world where the cost of goods and services are increasing. There's nothing wrong with healthcare workers actually being paid to distribute the services that we provide because they're needed. And so, healthcare spending keeps going up in this country. The only way that you were ever going to be able to bring it down is if people live healthier lives, and then ultimately that will put decreased pressure on the demand for services, leading to a decrease of spending as a percentage of GDP. How do you actually get there? Well, you need to make investments right now in healthy lifestyle, investing in exercising, using Kareem's, vegan smart products, okay? Obviously smoking cessation counseling, mental health counseling, cooking, learning how to cook and actually making healthy foods as opposed to eating processed foods. And if you do that over the long haul, we'll actually bring down the cost of healthcare spending in this country. But there are no easy solutions. This has been hundreds of years in the making. And I just wanted to make that point because that is my opinion and my experience in my years as a clinician.
Thank you, Dr. Roddy. Please, Dr. Boulware.
So I appreciate those comments quite a bit. I do think, there should be as much focus on healthy lifestyle as possible, but I also think we should couch that in the terms of what's being targeted towards people. Our worst quality, cheapest quality of food is always targeted towards the poorest individuals in our country. If you look at TV and you look at where people are, regular people are watching, look at the Super Bowl, heart attack on a plate. Everything that is being targeted towards Black individuals is the worst quality food. Black children who grow up in inner city don't have safe spaces to do exercise and aerobics. So I think one of the things that we should be faulted for in healthcare is saying, you as an individual, you take on the responsibility of doing all these healthy behaviors and healthy activities and find the healthy food, but yet the resources for people to get that are just not available. And I think that's a big disconnect. I don't want to at all disparage what you're saying, but I think there's a tendency in our society to blame the victim. And I think if we're really going to unpack this, we need to start looking at why is it that individuals, we all want to have a healthy life, but why can't everybody achieve that? Because we're not provided the resources and opportunities.
I will tell you this is my perspective. I have not written a book. I don't have $1 million company. I am just an OBGYN on the west side of Chicago with the patients. I choose to live in the same neighborhood as them. So when we talk about healthy living, when a patient's like, I'm trying to lose weight, but I don't know what to do, I'm like, me too, girl. So sometimes what we do is just sit there and think about places we could go to work out. So I'll say, oh, girl, there's a Y that's up the street, blah, 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 that you haven't thought about. And she's like, yeah, maybe I'll do that. I have so many patients who have fibroids. I have fibroids too. So I'm like, look, what I read somewhere is that a plant-based diet will actually help your fibroids. They can help to shrink them. And they'll be like, I don't like vegetables. I'll be like, me neither. But if you are having pain and if you're bleeding all the time and you don't want to have surgery because you told me every other doctor, the first thing they offered you was surgery, just try it. Let's you and I together say we're going to incorporate one of our meals, be a plant-based diet for 3 months. We do it together. The patient's like, yeah, it's not so bad. So I think that I'm very simple. I'm a simple person. The way I see it is, as a physician, my calling is to be with the patients and walk with them. I'm not ever gonna tell somebody to do something that I can't do myself or I don't expect of myself. And I choose to live around my patients so I can understand what they're going through. So I think that's a little bit of it. I think sometimes we do get so removed from our patients that we start thinking of things that they should do. But I think it's really simple. You just kind of identify with them. If we say that we love our Black patients, then we need to just identify with them. And that's just, I think, a real simple solution to a lot of our problems.
Well said.
Can I just add one thing, because I really loved how candid you were, Dr. Alexander, and just bringing it down and build real. So I have a very practical thing that I could ask everyone here that will help our entire healthcare system. And you guys heard I have a master's in bioethics. A lot of my policy and ethics focuses on end-of-life care, which is something that we as Black folks do really poorly. Yes. It's not a conversation we ever want to have. Yes. And I will tell you, when your loved one comes in and I have to make a decision about putting in a breathing tube or continuing compressions in someone that's 85 years old with stage 4 colon cancer, that's not a great time to have that conversation. It should have happened several decades ago. And so we spend approximately 33% of our Medicare spending on end-of-life care, right? This is what I'm talking about, why we spend tons of money in this country in ineffective care. that is just really not meant to be utilized in that fashion, right? You can't get compensated for a gym membership or to go shop at Whole Foods, but once you have diabetes, we'll spend however much you need for these medications and insulin and everything else. You know, we'll put you on dialysis, but we're not gonna prevent you from getting hypertension. It's so backwards. So the one preventative thing you can do that would make me so happy is that I want everyone here to think about their own mortality, what quality of life means to them, have a conversation with their family about what's important at what point, if I could never go outside again, if I could never feed myself, if I was constantly in pain, where I want my focus in life shifted to quality of care and not just days alive on this planet. And then share that with your family, document it, and have an advance directive. A particular platform you could use is mydirectives.com. Something that's electronically accessible makes it so much easier for a physician like me to have access it when I need. But this is an issue that I bring up on TV a lot because it gets very little play because we're all very uncomfortable with it, but it's extremely important. And when I have these documents and these conversations and families that are prepared, I can do such a better job with respecting individuals, respecting religious preferences, and respecting human beings at, you know, a very tender part of their life, which is at the end of life.
Yeah. And I know you have a comment, Dr. Bryant, but I want to expand on your comments to ask the panel a question. Because whether it's end of life, or whether it's attitudes about plant-based diets, or whether it's mental health in particular, we do have some negative notions in our Black community. We have some misconceptions. So how do we take those on? That's not on, quote, demand, so to speak. Yeah, it is, maybe underneath it, but we're in those communities. And what you just described for me, Dr. Alexander, is the definition of empathy, is being able to really put yourselves in the person that's in front of you's shoes, or in this case, the broader community. So how do we help overcome those notions?
So in terms of mental health, I want to just say transparency, boundaries, and joy. So in terms of transparency, we often wear the mask that grins and lies, that hides our teeth and shades our eyes. And we want to be mindful that transparency is contagious. And so usually we follow a script even with each other. So I'll let you all help me follow the script. If I say, how are you? You say,
Fine.
Fine and you, right? And then if you're churchy, you say, blessed and highly favored. So all of that keeps us silent. It keeps us silent and shut down and believing that I have to perform even for my own community. So I would invite each of us, instead of saying, how are you, to shift our question to each other to, how have you been managing with all of this? And then actually sit there and wait for an answer. Because people can read whether or not you really want to hear it or not. And we can create transparency by giving a real answer. And so during the pandemic with my children at dinner, I would say, you know, what is one thing that you miss that we haven't been able to do? And I would share something that I miss doing as well because everything was shut down. So it gives permission for more honesty. And then destigmatizing therapy, when we have more of our gatekeepers or role models openly talking about therapy and mental health, it opens a lot of doors. I had a pastor in Los Angeles who just heard speaking from the pulpit about being in therapy, gave so many people permission to say, well, if pastor could go, then I can go too. And then the second thing I'll say for our mental health is set boundaries. I was raised, as maybe many of you were, that if someone asks you to do something, you're supposed to say yes. You know, there's that service thing. And so I was freed at a women's retreat when a woman said, an evangelist said, just because you can do something doesn't mean it's your assignment. Now, for people who are multi-gifted, we have to hear that permission or else we are running ragged doing a million things and none of them well because we're exhausted. And then the last thing I will just say is Black joy is resistance. So yes, protest, organize, become CEO, do whatever the things you want to do, but know that it is a revolutionary act to nurture your joy.
All right, well said. Well, you know, my wife is not in the audience, but her latest theme to me, because everybody knows we're in some challenging times here, is Gene, don't let them steal your joy today. And that's picking up on that theme.
That's right.
Yeah, so, you know, we've got about 10 minutes left, and if there are no other questions, I want to...
I think there's a question there's some people who have questions.
Okay, I've been waiting for people. I didn't see anybody. Oh, please, come on. I'm sorry. My bad. Please, right here. Come on. Yeah.
Yeah, that's fine.
Hi. I don't know if it's on or not. My name is Zoe. I'm from Wake Forest University. I graduated last year with a psychology and theater double major. And this year I got to do a one-year fellowship, and I got to create a program for my university. Wake is a predominantly white institution, but I was thinking to myself, you know, what we really need is well-being for women of color, because maybe we don't. No, I'm joking. Well-being for women of color, because there's so much that we hold on to, and so much intersectionality. And I got to do the program and work with a bunch of different student groups on campus for 2 weeks, and it was great. And after I was done, they were like, okay, like, are you glad you're done with your program? And I said, this is just the beginning. Like, how do I institutionalize that and create more opportunities for women of color on our campus to keep having these difficult conversations for well-being and mental health, since it's so difficult to talk about, especially at predominantly white institutions?
Oh, thank you so much. I'm so glad for you doing that work. So a couple of years ago, I think 2016, I co-edited a book called Womanist and Muharista Psychologies, the Psychology of Black Women and Latinas. And so utilizing that as curriculum, you can do groups in your women's center or coordinate with your counseling center, or to destigmatize or to take it outside of the counseling center to work with your Black student government, so that it's an ongoing either drop-in group or people making a commitment for a certain number of weeks. And I love that you were also a theater major, because a part of our womanist model of healing is the healing power of the arts. And so that it doesn't just have to be sitting traditional talk therapy, but to use our movement, our dance, our poetry, our song, also makes it more accessible to people, and people feel less like they're being analyzed. So utilizing our artistry and sisterhood support.
Thank you. And I really apologize that I didn't start asking a question. Please invite me back nevertheless. Over here. Yeah.
Oh, this is really loud. Colette Brown Graham, Duke, class of 1984. And I actually went to medical school at University of Miami, so I'm really familiar with Miami. I'm an OBGYN, and what's interesting to me is that there is so much disparity in terms of maternal mortality, with so much stuff. I mean, a Black woman is 3.7 times, everyone knows this in this room, more likely to die than a white woman when we're going through labor, and it's just a shame. But I think one of the things that really makes me pause is that we don't have the same encouragement for students to go into medicine that are Black. And I personally think that would be the best thing, because they have so many studies that prove that a Black doctor taking care of a Black patient has a better outcome. So I have no idea why we're not just having this huge pipeline and encouraging our students to become doctors. I mean, I go to schools all the time, I'm like, how many of you want to be doctors? These are elementary school students. I want to be a basketball player. And I'm like, no, you want to be a doctor. It's the best thing in the world. So I'm wondering what you guys think about that, because I think the pipeline issue for me, I know we all need to do something. I'm working on the pipeline. I want more students of color to be in medical school. When I graduated, our number is not much better than it is today. I mean, I was at University of Miami, and this is my last point, and I asked this white guy to move over so I could take my picture on the wall. I graduated in 1989. He said, this wall is for medical students. I said, could you get over, please? My picture's right there in 1988, 80, yes. Can you get over so I can take a picture of myself next to my picture? And it was really interesting that he thought I couldn't be on the wall. So, and I don't think it's much better today. I think it's still, and that's where I think we need to really drive, to have other people of color take care of people of color, because I think we'll do better.
Yeah.
So,
That is such a wonderful point. At UIC, we do have a pipeline that we do with the medical students to recruit medical students into education to become medical students. And what she points out is something really important, particularly with maternal mortality. So most patients now believe that as well, that if you're a Black patient, you'll be better cared for as an obstetrics patient by a Black person. The problem is there isn't very many of us. So what happens is all of us take on all those patients, all of them. And so then what happens is what she talks about. There was a point in 2020 where I had to take a step back, where I was having visions of myself driving into a wall. Because I was like, I can't take care of but patients are like, I need you to be there. I'm afraid I'm gonna die if you're not there. And that really pulls on you dramatically. So I 100% agree with you that it is our responsibility as a physician to at least bring one or two people into the medical field. I want them all to be OBGYNs, but I want at least some of them to come into the field, and that just the little things that we do, the little conversations that we have with young people, we don't realize how much that really sticks with them and how much they appreciate that. So what you're talking about is just so monumental to the care of our people.
I'll be quick because I know we're running out of time, but the pipeline issue is essential, right? I talked about it in the beginning. We just don't have the representation. That's an actual accountability metric that institutions have to be held accountable for. And the way to get them there, and I've published on this in emergency medicine research about diversity pipelines, is there's a whole host of things that are preventing people of color from getting in medicine. Overemphasis on test scores. There's tons of data that shows, I didn't do super great on my boards, but I was chief resident. I'll tell you right now, I'm one heck of a clinician. Like I am, very, very good at what I do, but that doesn't necessarily reflect in the traditional, idea on paper of like what looks good in medicine and what looks good as an applicant. And so we have to change some of that framework, the way that we're evaluating, and we have to have representation on the admission committees, right, on leadership in order to open up those pipelines. But it's essential because otherwise the numbers will not change.
Yeah, very good point. One more comment. I know Ebony wants to say something.
I will say that here at Duke, we have a new Centers for Pathways programs reaching back into middle school, so that our focus is really to reach out into the communities, reach to the schools for individuals as early as possible to get them beginning to be interested in science and technology and engineering and medicine so that we can begin to build that, and also to instantiate cascade mentoring. So we have folks like us who are at various levels of our career, but there really aren't enough of us. We get overwhelmed with everybody coming to us who's of color for the mentorship. So we're beginning to build cascade mentoring programs so that we can really strengthen that pipeline, that pathway.
And you can tell those young kids that neurosurgeons make $1.2 million a year. So maybe, instead of playing basketball, they can look at careers like that. I mean, when I mentor kids, I let them know how much I make per year because they don't know, they don't understand that it's a way to sustainably actually build generational wealth in our community.
And I would tell you, you would be proud of Duke's track record in this regard, thanks in large measure to Brenda Armstrong. Her spirit lives on today. So when we talk about this at Duke, we are leaders in this regard because of her and her legacy and what she left us with. Please.
Yes, my name is Michael Theodore, Florida State University, go Noles. One of the greatest hip hop songs I ever listened to was Nas, Fried Chicken. The song in itself was a satire, talking about how we as Black people consume a whole bunch of negative stuff in terms of nutrients. Hip hop itself, to me, represents nutrients. You have hip hop that is wholesome, you have hip hop that is poisonous. I lived in Chicago for about a year. There's something known as drill music. People get shot, people go to the hospitals, people die. But hip hop in itself represents what? Black culture to a certain extent. So if you have an aspect of Black culture that is poisonous, that is cyanide to our people, but so much of our people listen to it every day, to the point that if you try to say something about it, you effectively get canceled. What should you do, especially if this is seen as a health problem for us?
I want to hop in here and say something about that. That's actually a really good point. You just have to be, to Kareem's point, and other people have made this on the stage, you have to be bold enough to actually tell people what you really think. And you have to divorce yourself from the idea of being scared to be canceled because you're going against a popular narrative. I agree with what you just said. I agree 100%. And I'll give you an example. I had a patient in the ER a few weeks, maybe a month ago. It was a young kid. He was 17. The kid was only a few weeks away from being 18 years old. Young black kid. I was looking in the kid's mouth. He had strep throat probably. I guess I looked to the wrong way. The kid got mad and cursed me out. So right in front of his mother. I looked at the mom. I literally just stepped back and looked at his mother. She didn't say anything. She talked to, I think she said something about, she's embarrassed. She said something about, oh, he has ADHD and we're still working on that. The kid had a cough or something. I sent him to go get an x-ray. I come back into the room and I tell the mother, I say, listen, your son's about to be 18 years old. I literally work in a black hospital in a black neighborhood that serves predominantly black patients, and most of our physicians are actually black in the hospital. And I told her, I said, this kid doesn't understand I'm an ally. Like, I'm literally here to help him. That's why I work here. And I said, do you want me to talk to your son? I can try to talk to him for you. Give him a little pep talk. Mother was like, of course. Tried to explain to the kid that, listen, man, you're only weeks away from being 18. I'm not going to be, I'm not offended or affected by you cursing me out, but you have to understand the world might not respond very well to that. I'll give you a mulligan today. And unfortunately, the little boy was not receptive to that message. So, and I just looked at the mother and that was pretty much it. But I still care enough to try. You have to still care enough to try. And I definitely understand, racism fatigue and just being, kind of tired that you have to take on this burden. But if we don't do it, who's gonna do it? You as a black man who went to college, went to FSU, I believe you said, if you're not gonna get up and talk to these kids, who's actually gonna do it? Because at least you have legitimacy, you have authenticity, and you can speak from the heart. And so that's just, it's our burden, it's our task. It starts when I don't have any kids, but if I did, they would understand this from the second they could understand my voice. Their training would begin from the second they could actually understand what I would be saying to them. And unfortunately, I don't know, maybe that's just not as popular in our community at times. It's maybe more popular to embrace some of these things that are toxic, but unless you actually have people like yourself and people on this stage and obviously people in this audience who are gonna take this message and then bring it to our communities, to uplift all of us, it's just not gonna get done. So I hope you challenged it, and I know you probably have. You just gotta keep that up.
Well said. If not us, then whom? If not now, then when?
Absolutely.
Leave it with you. Here, and then we have 2 more questions, then we'll wrap it up.
All right, my name is Joshua Crittenden. I'm a PhD student here at Duke. My question, I think you all touched upon it a little bit, but we do know that, again, thinking about black health, obviously pollution in the environment is a big factor on it. Here at Duke, I do environmental engineering research, and obviously you can organize at the local level. You have environmental justice groups throughout the state of North Carolina. However, when you go against large corporations who are the ones that are polluting our communities, I guess more or less, how do we intersect environmental justice, environmental policy, and then addressing black health disparities?
Well, I'll come in on that. Again, we're proud of the position that Duke has taken in general. In fact, with the aspiration to be the climate university, not just in the US, but around the world. I mean, here's a case where whatever your area is, make contributions through your area. If it's in research, make contributions that advance the whole frontier of renewable energy. If it's in advocacy, be on the front lines, advocating and pushing for policies. If you're in the community, it is just as Dr. Roddy was saying, you got to speak up, whether it's an individual or community group. So it requires action on behalf of each and every one of us in some form. It is one of those undiscussed major topics that affect in our community, beyond what we've been talking about, the more direct effects from racism and structural changes on health and healthcare? It's a great question. We're going to need to wrap up because I'm getting the evil eye, and I do want to come back again. So please give us your name and yeah.
Good afternoon. My name is Shayna Foxworth from Within University. I'm actually getting my master's there right now, and my final paper assignment is on addressing sex education in America in reference to South Carolina. And so it's a historical analysis, and so some things that kind of prompted me to do this is because I see the disparities and the inequities that we suffer from in the Black community, just from the sense of not even parents not talking to their children, them learning, educate about sex from friends and different things. So just kind of, my question is, how can we address this this inequity within sex education in our community in reference to even K through 12, sex education, because there's really no federal standard for sex education.
There isn't, but I think a lot of times it has to do with what the state laws are associated with that. And so that's why I think it's more important for people to be involved in local politics than national politics, because if you have something to do with like who's elected to the school board or who is the person that is, I don't know how everybody's, but I think about like who's the alderman of my area. If I elect someone who I know is going to go to City Hall and is going to stand up for having appropriate sex education, then I know that they'll make sure that that happens. And I think sometimes that we forget that local politics are really important, and that's the one that a lot of people don't vote in. And so we just really have to press in our neighborhoods that people go to the school board meetings and participate in who's voted as the school board and participate in who are all in our local politics, because that's just so important.
Okay, thank you for the question. We're moving to wrap up.
Two quick questions. Faye Dansby from Purdue University to Dr. Bryant, I think Dr. Claiborne also, and hello from the 4th Episcopal District of the AME Church as well. My question is, we hear all the time about happening, but we're in this massive country with many communities. Is there some place where they are working to dismantle and deconstruct racism and look at it from the healthcare side? There's got to be some community who said, we're going to tackle this and we're going to turn some things around. Do you have any example of that? And then also, is it helpful with having nurse practitioners now and physician assistants to help with that 5.6% number as well?
Sure, you want to, anybody, please.
Yes, thank you so much. So there are organizations that are providing training around mental health and creating curriculum. So I mentioned the Anti-Racism Handbook. There's also the Association of Black Psychologists. And so you can look on their website to see if they have a chapter in your city. And thanks to a lot of things moving virtually, we also do healing circles online. So the Sawubona Healing Circle is, Sawubona is from a Zulu greeting, which means I see you. And so these are free healing spaces that really use a narrative therapy approach where we tell our stories and then honor our humanity and our culture and spirituality as ways to approach our healing. I would also say that Division 45 of the American Psychological Association focuses on the realities of culturally diverse and marginalized clients as well.
And to your question about the mid-levels, I do think that that serves as an opportunity to have better representation and allow for race congruency, specifically in rural communities. And so, of course, I think that goes back to the pipelines. Like, people need to understand all the opportunities for healthcare careers, and they may not be aware, right? You can be a physician's assistant, you can be a nurse practitioner. You know, there's all these opportunities besides just doctor and nurse. And I think we're responsible for sharing that with our communities and making sure that our young people understand the myriad of careers that you can have in healthcare that truly make a difference.
Great. Last question, please.
This is the last question.
Yes, it is.
Thank you so much for the incredible guidance, the valued insight that you've given us. I'm Allison Reeves with the Collective. More importantly, I work in healthcare philanthropy, Doctors Community Medical Center in Prince George's County, so let's definitely talk. What I'd love to ask, and I'd love for us to even take notes, We're all incredible alumni leaders who are affiliated with some of America's largest universities. What guidance do you have for us, aside from putting some vending machines on our campuses, Kareem? Let's talk. Like, what guidance do you have for us to take back to these institutions to advocate to reduce disparities in healthcare that are race-related?
You have to have the courage to call it out. I mean, even in my own hospital, I mean, again, I'm a part of a system of hospitals, and, you know, I work in an indigent community in a black neighborhood. You know, why is it that we are underfunded relative to the other hospitals in that community? I mean, you have to, like, be willing to call that out. It's uncomfortable sometimes to have these conversations, and then, of course, when you might link it to race, I mean, we're predominantly, you know, serving a black clientele, lowered income community. Obviously, in the white neighborhoods, they don't have some of the challenges that we have. So you have to be willing to call that out. And, I mean, just, you know, being a leader in your community. Like Kareem made the point of opening the door and holding it open for the next person. I mean, break the door down. You know, be willing to mentor people, be willing to be a, you know, source of information. And, you know, obviously just do your best to bring value to your communities.
I would say that you need to ask for accountability in specific metrics. So a lot of institutions are going to jump on board and say diversity is important, we want to address health disparities. Put your money where your mouth is. I want to see money and funding being dedicated towards these offices for diversity. I want to see actual numbers of people in positions of leadership that are going to be able to represent the diversity that you think is so important. So I think that you can go back to these larger institutions and say, if this is important to you, I need to see how you're backing that up financially.
I would just underscore that Drs. Roddy and Claiborne are just spot on. But to get that accountability, you've got to organize and get as close to the top as you can. Mm-hmm. And the organization is important. I saw my chief of staff in here because the meeting I will have with an individual who comes to see me about some change is different from the meeting I will have with that same individual with a group. Mm-hmm. So we will often encourage someone, because it's her job to kind of say, well, okay, what do you want to talk to the chancellor about? And he would say that, and she would literally help them, you know, you need to come in and show that you are ready to actually move this. And believe it or not, you'd be surprised. Individuals in my role, we really are looking to be the best that we can be on behalf of the institution. And I happen to believe that that is the case more than you might imagine. And don't be surprised, though, because I've had some people who've tried to get into my office and literally they sit there tongue-tied and will say, I never thought I'd be able to get in to see you. Okay, but you're here now. But get organized, do some effort, but try to get. And to Dr. Claiborne's point, it's all about the accountability and it's about the transparency and holding people accountable. It's a great question, but get organized and go to the top. If you can't get in, call me. Yeah.
I was just going to say, go to your counseling center and encourage them to start a group to support students and possibly faculty dealing with racial battle fatigue. We have groups for eating disorders, groups for grief, groups for depression, groups for assault, and a large number of the students are really being affected by racism, and so the counseling center needs to address it. The psychology department on campus needs to have scholarships for historically excluded groups to become psychologists. And just to circle back to the question about hip hop, it is very important that we respond with compassion. We often say this lost generation, who lost them? We talk about them speaking poison. They have been fed poison. And so if we want to transform, then we have to help transform their experience by meeting them where they are.
Very well said. Before I yield the mic back to our big boss here, I want to thank you for coming, for your level of engagement. I want to thank the organizers for really bringing together this wonderful panel for this discussion. I really want to thank the panel. Thank you, everyone.
And thank you all. I'm just going to reiterate that thank you. That was an incredible discussion. We need to continue these conversations. There's tons of work for us to do, and we appreciate you all for coming out and speaking to us candidly. I'm going to get on a plant-based diet. I have fibroids. So thank you so much. That was really an amazing convo. So we are going to take a break. Apologies on going a little bit over. This was such a rich conversation. We're going to try to get back as quickly as possible. We are supposed to start our next one at 4. We'll give it about 5 minutes. So take a break, use the restroom, and then come right back in.